Verify has a handout that is on your desk for you to review. Also, yesterday I forgot to announce or to make sure that everyone had received the emails from Blue Cross and Blue Shield of Kansas and Cigna concerning Senate Bill 175 and the amendment. So just want to make sure everybody had an opportunity to read those and the reason for that amendment. So with that, we are now ready to move on to our hearing on Senate Bill 200, expanding the pharmacist's scope of practice to include point of care testing for and treatment of certain health conditions. And first up, we will have a bill explanation from Jenna Moyer. Jenna?
Yes. Good morning, Mr. Chair, and thank you, members of the committee. Senate Bill 200 would expand the pharmacist's scope of practice to include point of care testing and treatment for certain health conditions. And the majority of changes in this bill happen in Section 1, and it would allow a pharmacist to independently test or screen and initiate therapy pursuant to statewide protocols, which would be developed by the Board of Pharmacy to treat certain health conditions, to test and to treat for those certain health conditions. And the ones listed in the bill would be things like flu, strep, the test for COVID-19, and pre or post-exposure prophylaxis, as well as another waived test for clinical laboratory improvement amendments. And this would allow the pharmacist to both test and screen for conditions that require minimal treatment or self-care, and the board could expand, the board would be required to establish statewide protocols and enforcement to just ensure that pharmacists are performing the tests and treatment in a way that is acceptable to the board, as well as enforcement. And then the remainder of Section 2, it just updates the current statutes for the pharmacist to include references to this scope of practice expansion. And with that, I'll be happy to answer any questions.
Jenna, thank you. Committee, do we have any questions for Jenna on the bill? Not seeing any. Jenna, thank you very much. Committee, we will now turn our attention to the proponent testimony. First up, we have Mitch DePriest with the Kansas Association of Chain Drugstores. Mitch, welcome to the committee.
Thank you. Looks like the mic's on. Mask good? Hear me? Okay. Mr. Chair and members of the committee, my name is Mitch DePriest, and I'm testifying today on behalf of the Kansas Association of Chain Drugstores, trade association of chain pharmacies in the state of Kansas, which employ more than 32,000 Kansans and over 500 pharmacy locations. In the last year, we've been proud of the way that our pharmacists, pharmacy technicians, and operation teams have stepped up in responding to the changing preferences among consumers and a nationwide testing regime, and how now the many millions of vaccines that will be necessary to bring this virus under control. In this changing environment, we have discussed how pharmacy's unique advantages can be utilized in addressing other common health conditions, just like the legislature had provided in 2017 when passing statewide protocol for dispensing naloxone directly to a patient under a physician's authorization. Some of these conditions we would aim to address, and when asking for your support of SB 200 would include influenza, streptococcus, and urinary tract infections. Kansas pharmacies already are able to provide for the testing of these conditions through an FDA-approved process that identify the tests are being able to render the likelihood of erroneous results as negligible to the extent that they are often available for home use. However, Kansas pharmacists are not able to provide what are at this point fairly standardized treatments for conditions. You might wonder about the experiences in those states, and studies in the last decade have demonstrated patients were able to better address their conditions before requiring emergency care, as 38% visited outside a normal clinic's hours, and 54% did not have a primary care provider. Lastly, I would note that in proposing the legislation before you today, we had reached out to other stakeholders Well, we understand from these conversations, there are some that may have a different opinion you may hear from today. We still think SB 200 provides patients an option when considering their anxiety surrounding infectious diseases may persist far beyond the pandemic. Thank you for the time today, and I would urge your support of SB 200.
Mitch, thank you for your testimony. And committee, we will hold questions until all proponents have had an opportunity to testify. Next, we have Tanya Mclean. She's the Market Health and Wellness Director for Walmart.
Good morning.
Tanya, welcome to the committee.
Good morning. Thank you all. My name is Tanya Mclean, and I am the Market Health and Wellness Director for Walmart here in the state of Kansas. Can you hear me okay? Can you hear me?
Tanya, try talking again if you don't mind, please.
Can you hear me now?
If you can just turn up your mic a little bit on your end, just a little bit, or turn up the volume, and I'll adjust on my end, and we'll work it out.
Okay.
There you go.
Is that better?
Yes, it is.
Okay. Thank you. Good morning. My name is Tanya Mclean, and I'm Market Health and Wellness Director for Walmart here in the state of Kansas. The stores I oversee are in the greater Wichita, Kansas area, and I've been a pharmacist in Kansas for 19 years. So thank you for having me today to testify in support of Senate Bill 200, which would expand the scope of practice for pharmacists. As a Market Health and Wellness Director, I'm super enthusiastic about the prospect of increasing our ability to serve patients and to improve and protect the health of our community. For many Americans, pharmacies are extremely accessible providers of health and wellness services. In fact, more than 90% of Americans live within 5 miles of a pharmacy. Additionally, the uninsured have access to care in the pharmacy that they would otherwise not receive. We see many positive impacts on patient outcomes from care we provide. Whether it be a wellness day where we're providing screenings such as blood pressure, blood glucose, and cholesterol screenings via our Narcan protocol that enables us to provide life-saving medications so our patients can avoid overdose from opioids. We impact lives and save lives daily as we bridge the gaps that provide barriers to healthcare for so many. I could tell you countless stories of lives we have saved by finding undiagnosed conditions such as hypertension, diabetes, and the uninsured. We also have numerous patients who return to the pharmacy and say if it were not for the Narcan we provided, they would not be standing there talking to us now. Increasing accessibility to basic health services is not just about convenience. It truly saves lives. Nationally, streptococcal infections result in 45,000 cases and 2,500 deaths each year. And in Kansas, roughly 2,000 people lose their lives annually as a result of food-related illnesses. Permitting pharmacists to conduct point-of-care testing and treatment will expand access to healthcare for common and easily treated health conditions like influenza and stress. And if pharmacists were empowered to act upon positive point-of-care test results, they could diminish the severity of the impact. Beyond improving accessibility, increasing the scope of practice for pharmacists in Kansas would improve affordability. This applies to both the financial burden and untreated illnesses on the healthcare system and the cost of care for patients. Identifying and treating illnesses early can result in better long-term health outcomes and therefore diminish the financial impact that severe illnesses can result in. Many pharmacies are also able to provide services at an affordable price point. The impact that affordable pharmacy services could have on citizens of this state is illustrated by a sobering statistic of over 13% of Kansas report not seeing a doctor in the past 12 months because of cost. Many times, high cost to healthcare consumers and payers spike when minor illnesses are left untreated due to lack of access to care. I feel we are well trained and uniquely positioned to provide these services in a very accessible and affordable way. not only from a formal education perspective, but also from a continuing education perspective. Pharmacists are educated about the medications, but also the underlying disease state that these medications treat. We have access to continuing education on new and emerging therapies and have shown the ability to pivot and learn new clinical processes to serve our communities in times of need. For many months, pharmacists have been on the front lines of the pandemic, risking their own health to provide crucial services, COVID-19 testing, and now leading the charge to vaccinate patients against the virus. Even before the COVID-19 pandemic, pharmacists were playing a significant role in ensuring that Americans were vaccinated against common and preventable illnesses. In 2018, 32% of adult flu vaccine recipients were administered the vaccine in a store or pharmacy. In 2019 alone, pharmacists administered over 45 million vaccines across the U.S., with 500,000 administered here in Kansas. Along with physicians, therapists, nurses, techs, and pharmacists, we're trusted members of the team that care for patients in our state. We are well positioned to provide accessible and affordable health services. For these reasons, I urge you to support SB 200 and to support pharmacists around Kansas. Thank you so much for allowing me to speak with you today, and I look forward to answering any questions you may have. Thank you.
Yeah, thank you for your testimony. Committee, we will now turn our attention to Amanda Applegate. She's a pharmacist with BCACB Balls Food Stores. Amanda, welcome to the committee.
Morning, and thank you for having me. As you mentioned, I'm a pharmacist with Balls Food Stores in the Kansas City metro area. 13 pharmacies in the state of Kansas, and we run under the banners of Hen House, Price Chopper, and Sunfresh pharmacies. So those of you in the Kansas City metro area have probably heard of a few of our pharmacies. I will be the first person to say that this test and this testing protocol is not probably applicable in all counties in the state of Kansas. However, as some of our previous speakers have mentioned, this is something that can be very applicable for patients that may not have a primary care provider, patients that may not have easy access to urgent care or primary care, or patients that may not have broadband access, allowing them access to telemedicine that has been expanded greatly during this pandemic. On my drive to work to our corporate office every day, I probably drive by no fewer than 4 urgent care facilities in my Johnson County area. And so this is not something I would be eager to apply in some of my Johnson County pharmacies. However, in some of my pharmacies in Wyandotte County and Leavenworth County, where there are shortages of primary care and urgent care availability, this could be something that could be easily applied in these types of areas. In the state of Kansas. Some of the first things that we learn are how to tackle common we see in community pharmacies. We learn things such as how to identify some common over-the-counter clinical instability in these patients. So somebody that probably shouldn't be treated by over-the-counter and somebody that does need to see a more advanced level of healthcare professional quickly or as soon as possible. These are some of the first things that we learn, and these are some of the things that our pharmacists prescribe, right? Pharmacists see in their pharmacies every day. We learn how to weed out who can and cannot be treated, and this is something that is going to be very narrowly defined in protocols that would be implemented by the Board of Pharmacy. In looking at samples from other states that have been doing this for several years, they very narrowly define who the pharmacist can treat with very careful inclusion and exclusion criteria, looking at things such as if a patient has blood pressure that is out of range, oxygen saturation, or high temperatures that may necessitate a referral to an urgent or emergent level of care. And then also things that may or may not make the medication work well, such as if with both flu and strep, it's important to treat it as soon as possible, especially with flu. You do want to have it treated within the first 48 hours of symptoms arriving. And in my case, even in my Johnson County area, sometimes I'm not able to get in to see my Johnson County physician in under 48 hours of having symptoms start. So that is something where the speed of treatment can make a difference in the clinical outcomes of the patient at that point in time. And that's where, when the Board of Pharmacy helps write these protocols, they're able to very narrowly define who the pharmacist can and should be helping. And then once they identify if they can and should help this person, they are very narrowly restrained in, what they can and cannot prescribe. When it comes to something, again, I believe was mentioned earlier, these are things where there is a very narrow scope of what should be treated. There's not a lot of dosage criteria that may be necessary. So this is something where when the pharmacist does that test, it comes back positive, they're very easily able to follow the protocol to say, here's what we should go ahead and dispense to this patient, and then help follow their recovery and report what they've done to the patient's primary care physician if they have that applicable. Again, this is something where if in areas with shortages of primary care physicians and shortages of emergent and urgent help could be something that could be easily implemented and narrowly defined by the Board of Pharmacy and executed by our Kansas pharmacists. I urge your support of this bill, and with that, I will stand for questions at the appropriate time.
Thank you very much for your testimony. Committee, that does conclude our oral testimony. I will draw your attention to written only. We have written only by Alexandra Blasi, Kansas Board of Pharmacy, Aaron Dunkel, Executive Director of the Kansas Pharmacists Association, Rob Tinsley, CEO of Curis Industries, Pharmacies of Kansas, and Elizabeth Patton, Americans for Prosperity. Is there anyone else wishing to testify as a proponent on Senate Bill 200? Okay, not seeing any. Committee, we will now open up for questions. Do we have any questions for the proponents? Senator Stephan.
Thank you, Chairman. Frankly, this is so full of holes, I don't really know where to start, but I'll find a spot. Can anybody tell me exactly in your pharmacy training where you were taught to diagnose and treat? Is one. Another, well, I won't abuse my opportunity to ask questions, at least until you tell me to stop. Explain your training in pharmacy school as to diagnosis and treatment. You talk about urinary tract infections. Are pharmacists trained to define the 10 different causes of UTIs and the variations in the clinical presentation and the treatments thereof? Is that part of your pharmacy training? Let's start with those two, please. And thank you.
I will take the opportunity to respond to that. I would say that as far as our pharmacy training and how we handle things that we currently do under protocol, that we work in conjunction with the physicians, not only who are treating the patient primarily, but also within the standing protocol. So we're a part of the healthcare team, not operating independently, in our role. So I would say, there are other things that we do in this manner, and we operate as part of the healthcare team. And although we have education in the underlying disease state, we would still definitely depend on all of our healthcare partners to team up and to treat the patient to provide the best care.
Thank you. For those of you listening online, that was the question was answered by Tanya Mclean, Market Health and Wellness Director for Walmart. Conferees, I would ask that when you do answer a question, if you would state your name and identify who you are representing. That way those that are listening online will know who is talking. Committee, do we have any further questions? Senator Petty.
Thank you, Mr. Chairman. And I'll address this to Amanda Applegate. There in the bill on page 1, line 18, letter F. I'm wondering how broad that makes, or does that broaden the pharmacist's ability? There's a specific listing 1 through E, and then F talks about a condition for which it is So Amanda, could you speak to that? How much broader does that make this section?
This is Amanda Applegate from Ball's Food Stores in the Kansas City metro area. I apologize. I'm pulling up that specific piece of the bill. I didn't have it right in front of me right now. Can you repeat? You said the list in those lines 13, 14, 15. Is that where you were looking?
Correct. And it's line
Okay.
18, letter F.
Yes, so in this case, the condition for which the diagnostic test is waived under the Federal Clinical Lab Improvements Amendment, what this is it addresses a specific category of testing devices, such as something like an influenza test, or in this case, everybody's fairly familiar with a COVID-19 rapid antigen test. What these devices are they're considered waived, so they are not applicable under the Clinical Laboratory Improvement Amendments. And again, a lot of these devices, I believe Mitch DePriest mentioned, are devices that are approved even for home use in some cases. And what they do is they return a very simple positive, negative, or inconclusive result, such as when I am doing a COVID antigen test, I'm getting I think fairly similar. People use the analogy of a pregnancy test. It's either positive or it's negative. Sometimes there's an inconclusive, and in either of those cases, you're allowed by the protocol to define yes or no. So there are not an abundance of these type of devices approved at this point. And so, as these types of tests continue to expand, it's possible, but I would say at this point it is fairly unlikely. Flu, strep, and COVID-19 are very, very much the most common types of tests that would be allowed under this.
Mr. Chairman, just as a follow-up, is there any conflict between that new section 1 and then the collaborative drug treatment management that's already spoken to in the bill?
Yes, I don't believe so. These are going to be landing under 2 separate things. So I do sit on the Kansas Board of Pharmacy's Collaborative Drug Therapy practice committee, and they're separate in a couple of different ways. So the collaborative drug therapy practice allows for a very narrow scope in that a patient that already has an established relationship with a physician or provider can go to a pharmacist for specific types of care. What this protocol does is expand access to people that do not necessarily have that established relationship provider or have an established relationship with a provider that's nearby. So they do help, again, with 2 separate populations in some cases. So I don't see them as counter to each other.
Thank you.
Senator Gossage.
Thank you, Mr. Chair. I'm looking on line 12 on page 1, where it says, for the purpose of this section, a health condition is a condition that is generally managed with minimal treatment or self-care and includes, but is not limited to. So if it's not limited to the flu, strep, or COVID, what else? And I think this might be a concern of what else might be, and is there a limit on what the pharmacist is able to test and treat?
I think technology this is Tanya with Walmart Market Health and Wellness Director. I think that technology is continuing to emerge, and primarily those are the conditions we are currently seeing, treated and tested for in other states. So as far as the scope of that and how it would expand, I wouldn't be able to speak to it at this time. But again, there are very common conditions that are being treated and tested for in other states, and namely streptococcal and flu.
And just a follow-up question, thank you, Mr. Chair, can you explain or someone explain what is the limitation now compared to what you're asking for here? Because I know you can go get a COVID test at many of the pharmacies, Walmart included. One can get an influenza test, correct? So
Yes.
what are we asking in addition here to what's already being done? What am I missing?
In Kansas, we currently are not doing influenza and streptococcus. So I think that's the immediate concern that we're addressing here. And maybe Amanda could share her perspective on that as well.
Yes, as you mentioned, we are allowed to do the testing at this point in time, but we are not allowed to do anything as a result of that test. So I can tell a patient, yes, you're positive for influenza A, but I can't do anything to treat that condition at that point. So I can tell them exactly what they need to do, exactly what needs to happen from here, but then they have to make an appointment with a provider in order to get the prescription, in order to then bring back to the pharmacy to fill. So again, I can tell them that somebody has tested positive at this point in time in the state of Kansas, but I can't do anything about that positive test.
Thank you.
Senator Thompson.
Thank you, Mr. Chair. I'm just curious, on page 1, line 24 through 26, who are individuals who publicly profess to be a pharmacist? I mean, that could be anybody, I played a doctor on television one time. I'm just curious,
This is
Oh,
Amanda.
Weatherman, yeah.
Sure, I'll defer, I think, to the revisers on this one, but I believe that that's part of the current practice law is why that was included in there.
Okay, I'm just curious because I think that would open the door to snake oil salesmen, I think.
Jenna, do you want to clarify that or?
Mr. Chair, I'm going, just so I don't speak out of turn, I'm going to look that up and make sure. But this is not the licensure statute. To be able to practice pharmacy in Kansas, you have to be licensed as a pharmacist. So I just want to clarify, this won't open up the scope of practice to people pretending to be pharmacists, but I will double check on what this is interpreted as.
Thank you, Jenna. Committee, I see no more questions. Senator Stephan?
Thank you, Chairman. Just one more quick one. In medical school residency and such, you're taught that a test is a piece of the puzzle to arrive at a diagnosis, as is a physical exam. And you never base treatment just off of a test result. It helps guide your treatment protocol. So I haven't heard anybody talk about physical exams. I haven't heard anybody talk about putting test results into context with clinical symptoms. Does anybody want to comment on that and as to a pharmacist's training and pulling all that together?
I can comment on that. This is Amanda Applegate with Walls Food Stores. One of the things, and I mentioned earlier in my testimony that this is very narrowly defined in how we are allowed to evaluate a patient. So in the protocols that we see in other states, it does require obtaining of vital signs such as blood pressure, pulse, respiratory rate, oxygen saturation, and temperature before we would even do the test on that patient. So we would need them to be a clinically stable patient and evaluate. So if I had somebody, had a blood pressure of 200/100 and they were asking for a test for influenza, this isn't something that I would even consider participating in because that person needs to be immediately referred to a higher level of care than a pharmacist can provide. But if somebody appears clinically stable, they meet all of the inclusion criteria for the protocol and result in a positive test, that could be something that we do go ahead and treat at that time. And on the flip side of that, if somebody is clinically stable, they meet all of those specific criteria, and they come out with a negative test, we can absolutely refer, and we do on a regular basis without testing, refer to over-the-counter therapy, such as treating the cough and cold, or again, refer them to, hey, you have a negative test. This is something that if you're interested in pursuing this further, does need a follow-up with a provider as soon as you can get to normal clinic hours, or have somebody drive you into town to get that type of access.
Committee, we will now move on to opponent testimony. First up, we have Rachelle Colombo, Executive Director for the Kansas Medical Society. Rachelle, welcome to the committee.
Thank you. Good morning, Mr. Chair, members of the committee. I am Rachelle Colombo, the Executive Director of the Kansas Medical Society, and I am here today on behalf of Kansas physicians. We oppose Senate Bill 200. It was mentioned that, that the proponents of the bill tried to reach out to stakeholders, and we did receive notice of this bill about a couple of days before it was introduced. I would tell you that pharmacists and physicians have a long history, our organizations, of working together and making sure that we are working in the best interests of patients. That's really important, and there's been a number of things already established in law that reflect that, including protocol language and drug management collaboration, which you asked about, Senator Petty. And so there are a number of ways some of these things can be addressed, but I would tell you that we oppose this bill, and while it has been, I think, presented as pretty minimal and narrow in scope, the questions you've asked actually reflect how very broad this is. Specifically, it's allowing a pharmacist to test and then treat a patient independently, and while it lists just a couple of conditions, as you asked, Senator Gossage, it is not limited to just those conditions. It would be anything that is approved by a protocol established by the Board of Pharmacy. So the Board of Pharmacy could independently determine which conditions they believe ought to be independently tested and treated by a pharmacist. And we believe that is far outside the scope and training of pharmacists, and it doesn't reflect the systems that are already in place to allow for what was talked about by one of the conferees, increased access. And there was an answer about making this available to a broader population. I would posit a broader population of pharmacists who may not have that relationship with a physician that can be established to allow them to treat for these sorts of things in the appropriate setting. So, and additionally, it also says that a pharmacist could independently and immediately dispense any drug they believe to be necessary to the imminent well-being of a patient. That is a really broad expansion. And if it is believed that this is in the best interest of the patient, then I think it begs the question why a physician couldn't independently dispense at the point of care. That's something that is not currently allowed. A physician prescribes, but they do not dispense medication. That is the sole purview of a pharmacist. And so I think that we should ask the question why. And also, I think the conferees appropriately said they could, under this, they'd be able to test, but currently they're not able to do anything about it. And in the bill, it's called, they're able to, drug initiation. That is a new way that's a new word for prescribing. That's what that means. They would be able to independently then prescribe, which is currently something only a physician can do. So this is a very broad bill. It is, I think, presented as just dealing with what are common infectious diseases. You asked also, Senator Gossage, I believe, about the flu test and about COVID-19. The flu test is something, and flu shots are something that under a standing order, pharmacists can provide. Also, we have looked at COVID-19. That has been established in a different scheme through a standing order as a result of course, the pandemic. So I would posit that there are ways for us to address those things that are routine and necessary. We've had ongoing conversations for the last couple of years about maybe statewide protocols that ought to be established for things that are routine and would serve both patients and providers better in collaboration. And we'd be happy to continue those conversations, but we don't believe this is the right place to begin and would respectfully urge you to oppose Senate Bill 200. And I'd be happy to stand for questions.
Thank you, Rachelle. And committee, we will hold for questions until all opponents have had an opportunity to testify. Next up, we have Dr. Chad Johanning, President of the Kansas Academy of Family Physicians. Doctor, welcome to the committee.
Thank you, Chairman, and thank you to the members of the committee, and thank you for the opportunity to appear today in opposition to SB 200. My name is Chad Johanning. I'm a practicing family physician in Lawrence. I'm also currently serving as the president of the Kansas Academy of Family Physicians. In Lawrence, I've treated patients for the last 12 years with effective team-based and evidence-based care. Proud to provide my patients a medical home and a place where they have access to care at all times, given by a group of team-based clinicians providing highest quality patient care. This is achieved by providing 24 hours a day, 7 days a week access to my patients, as well as to walk-in clinics to promote continuity of care. Research has demonstrated that patients are best served in an established medical home by a physician-led care team, and that's the best model to safely and efficiently meet healthcare needs. For that reason, KEFP opposes Senate Bill 200 for 3 reasons that are critical for patient care and safety. First, the bill goes at the heart of an established medical home and further fractures healthcare delivery and service. The bill treats the listed conditions as if they can be separated from the whole of the patient's diagnoses, treatment, and healthcare needs. So we oppose any legislation that serves to fracture healthcare treatment, thereby creating greater risk to patient safety. Our second issue with Senate Bill 200 is that it contemplates, as mentioned before, pharmacists engaging in the practice of medicine as defined by Kansas state statute. The statute clearly delineates what constitutes the practice of medicine and further establishes that only physicians shall be licensed to engage in these practices. But finally, the bill does not really provide a procedure for when simple cases become more complex. It infers that caring for illnesses where management is, quote, generally managed with minimal treatment or self-care, as someone mentioned before, is risk-free, and pharmacists should therefore be able to care for these illnesses via collaborative agreement. The diseases specified in the bill as low risk actually sometimes carry very high risk. For an example, strep throat. It can have life-threatening complications such as abscesses that need to be drained, such as enlargement of tonsils that can impede the patient's ability to breathe. And each of these complications involve examining the patient. This is not just a test that you can get a positive or a negative result for, give them an antibiotic and send them out the door. Each of these complications would obviously be outside the scope of a bill, as they are not self-limiting, but the bill does not adequately describe how pharmacists would be able to identify these serious complications and refer them to the most appropriate treatment venue. Collaborative agreement with a physician would not solve this issue of the scope of practice, and the patient's health is at risk without proper training. This bill and other bills that propose to expand non-physician scope of practice into the practice of medicine share a common theme. They're focused on healthcare professionals' desires to practice medicine rather than what's safest for Kansans. We ask the committee to consider most highly what long demonstrated research tells us is best for patients, an established medical home with a physician-led healthcare team, and reject Senate Bill 200, which would fracture healthcare delivery, allow non-physicians to engage in practice medicine, and put patient safety at risk. And I thank you, Chairman.
Dr. Johanning, thank you for your testimony. Committee, next up, we have Christy Clark, MD, and she is the president of the Kansas chapter for American Academy of Pediatrics, and she is joining us via WebEx. Doctor, welcome to the committee.
Thank you, Chairman and committee, and I hope everyone can hear me. My name is Dr. Christy Clark, and I'm a board-certified pediatrician. I've been a physician for over 20 years, and I practice in rural West Kansas for over 10 years. I currently serve as the president of the Kansas American Academy of Pediatrics, which represents over 400 pediatricians that practice in the state of Kansas. And I'm here in opposition to this Senate bill. When we look at the bill, it allows for an increased scope of practice for pharmacists. It allows them to run labs and treat what they're calling self-limited conditions. I'd like to point out that the bill doesn't even have diagnosis in between running the lab and treating, which honestly shows how short-sighted this bill is and possibly unconcerned with patient safety. This really is the practice of medicine outside of the Kansas Board of Healing Arts. The practice of medicine is outside the scope and training of pharmacists. When I was doing research for my testimony, I only found 7 other states as of November of 2020, which were allowing for this. And 4 of them required advanced training in terms of hours and hours, hundreds of hours, as well as preceptorships with physicians. Pharmacists are an incredibly valuable member of our healthcare team. They're very well educated. Beyond 4 years of college, they have 4 years of graduate level training, most of which is in pharmacology. And I'd like to refer you to KU's curriculum for pharmacists as part of my testimony. They validate doses. They check for allergies. They look for drug-drug interactions. I would not want to practice medicine without my pharmacist, and I would hope my pharmacist wouldn't want to do his job without me. Their training is very different. Physicians, after 4 years of college, we have 4 years of medical school and 3 additional years of clinical training in our residency. We are taught physiology of disease, how to take a history from a patient, physical exam. We're taught how to evaluate diagnostic tests such as labs and radiology. We're taught to form a differential diagnosis, which means not just one thing, but what are all the different things that could be going on here? What's the worst thing? And sometimes our treatment includes medications. We believe that this would fragment care and cause some very serious documentation issues as well that could affect patient safety. These minor conditions that are listed are not minor. We have serious concerns. There's no age limits on them, and there's no limits on the range of the diagnoses that they can treat. I would also like to use strep as an example, just to illustrate how complex this is. A child could come in with fever and sore throat, and they could test negative for strep, be told to go home, maybe it's just a virus, and that child could actually have mono with an enlarged spleen that's not caught because the child wasn't diagnosed. They could go on to play contact sports, that spleen could rupture, and they could die. Or they could have Kawasaki's disease, which can cause coronary artery aneurysm and long-term heart problems for that child. So just because the strep test is negative doesn't mean that we stop there as a physician. Furthermore, someone could have strep, be prescribed an appropriate antibiotic. They could go home and have a very serious consequence to their strep. I know we talked about abscesses, but you could also have things like post-streptococcal glomerulonephritis that affects your kidneys. You could have rheumatic heart disease that affects your heart, or the child could have an allergy to that medication. And because that child did not go to their medical home, they didn't go to their primary care provider, that is not placed on their chart, which could put that child at risk for being given that antibiotic again if they were to go to a different physician and see a different pharmacist. So I hope that illustrates for you, that's just strep. I originally had urinary tract infection in my testimony, and I felt like that was so complex that it was outside the scope of this written testimony that I could provide for you. These conditions, again, they are not minor. They can be very serious, and they need to be seen and taken care of in context of that relationship that the patient has with their physician. Another concern I have, and I want to blatantly point it out, is that the people that are giving testimony for this bill work for large corporations. I am a rural physician working at a rural health center in an underserved area, and I can tell you that these things will not increase access to healthcare out where I live, where we have shortages. What I anticipate is that it will be the big box stores, corporations from outside of our state, which will be profiting from this by exploiting pharmacists and our residents here in Kansas. I want to be very blunt about that. Again, I'm Dr. Christy Clark, and the pediatricians oppose this. Thank you very much. I'm open for any questions.
Clark, thank you for your testimony. Committee, that does conclude opponents. Do we have anybody else wishing to speak as an opponent? Not seeing any. I would like to direct your attention to written only. Vicki Whitaker, Executive Director for the Kansas Association of Osteopathic Medicine, and Travis Aller, Executive Director for the Kansas Chiropractor Association. Committee, we will now open for questions. And our first question, Senator Baumgardner, Senator O'Shea, and then Senator Gossage.
Thank you, Mr. Chair. I don't know that this is so much of a question, but I do want to make a few statements and comments with reaction to the opponent testimony. I am not going to address the training and the practice differences between a pharmacist and a physician. I am very familiar with them. But what I do want to address is what I feel is a very tone-deaf message that we're receiving. When we talk about Kansans receiving 24-hour-a-day, 7-day-a-week care. And I think that that was the testimony that we received from the Kansas Academy of Family Physicians. That has absolutely not been available to Kansans, particularly during the pandemic. What I know to be true in my rural as well as suburban Senate district that I serve, a majority of residents do not have a family physician. So to say that these services are being provided and that's where families should go, again, that tone-deaf message is the lack of recognition that that is not what families are doing here in the 21st century. With regard to COVID and where we are right now, family physicians did not allow patients to go in. We have a colleague in the Senate contacted her family physician because she suspected she had strep throat, was denied to be able to come in to the office, was told to go to Emergis Center, a walk-in clinic, went to the walk-in clinic. They said, well, you don't have an appointment, rejected there, had to go to a hospital to get the testing just to find out didn't have strep. The services have not been provided for families and residents of Kansas by our physicians during this pandemic. I understand the concern of the spread of COVID, but people were forced to go to emergency rooms and then had to stay. We have some folks that have had to stay in emergency rooms for more than a day waiting for the COVID testing. And with regard to the testimony that I think we received from the American Academy of Pediatrics, go ahead and attack our large corporation and the box stores. But the bottom line is, without their assistance in our state, that is where a majority of the COVID testing has occurred since the start of the new year. And quite frankly, that's what's going to help us deliver the immunizations, the vaccines, if you will, to our elderly. That's what's going into our nursing homes and getting them vaccinated. That is what's going to help us get Kansans vaccinated. So, Mr. Chair, my biggest concern is that it does not appear that these groups have worked together. And when I look at the spectrum of healthcare, where would the physicians be without the pharmacists? Where would the pharmacists be without the physicians? They darn well better start working together, coming up with a real solution for Kansans, and we're not there yet. Thank you, Mr. Chair.
Senator O'Shea.
Thank you, Mr. Chair. I want to also ask the opponents, give us an alternate solution. Because when I think about it, not everyone gets to go to the doctor. Not everyone has the time to go and spend however many hours. It takes months sometimes to get in. I'm blessed to have a family physician that canceled an appointment on me and it couldn't get rescheduled for 6 months. So what I like about this is it's a solution to some of these challenges, to access, to cost. And so if not this, then I would ask the opponents what can we do? Because I would also say that there's illnesses that aren't being addressed and people are dying already because they don't have access to a doctor. So that's my comments. Thank you.
If I may, yes, Rachelle Colombo, Kansas Medical Society. Thank you for your question, Senator O'Shea. I think that that is a good question. And what I would say is that Senate Bill 200, if we were to narrow it down and look at the way it's presented versus what it's actually doing, we could probably get somewhere. I think that this is far too broad. And we have in the past many, many times, and there is, like I said, this process for collaborative drug therapy management. But there are also times when we have by statute said, in these instances, on these particular health conditions, we're going to allow something specific. And that's not a conversation that happened between pharmacists and physicians before this bill was introduced. The other thing that it does is this bill says, well, it's these conditions and it's all of these things. It's not just testing. It's testing, treatment, prescribing, and immediate dispensation of these drugs without any physician involvement. So it's not one or the other. There is a way to say, Well, if these conditions need to be treated or tested for, then where's the callback to the physician, and so that it stays as a part of the patient's medical health record? If they don't have a physician, that's something we address in statute. That's something that we can do. We can also say it doesn't need to be treatment. It doesn't need to be any other health condition as defined by the Board of Pharmacy. Where is the role of the healing arts? Why is the protocol only defined by the Board of Pharmacy? So how are they developing a protocol, a medical protocol, without any input from physicians? We would say that this bill, if the question is access and how to get more treatment that's actually going to be the right treatment for patients, let's not just cut physicians out of it entirely. Let's make sure that it's actually collaborative, because that's going to serve patients better. So I think that's the problem with this bill, is it says, we just want to do a couple things because we think these are falling through the cracks. But it's not working together on those. It's just subverting it over here.
Senator Gossage.
Thank you, Mr. Chair, and I completely concur with my fellow Senator Baumgardner that I see these two groups that should be working together, and I'm not seeing that today. I know in the past, if I thought I had strep throat, the doctor would say, it's going to take a while to get that test back. I could take a few days. I'm going to go ahead and treat you as though you have strep throat because you have all of the physical signs of that. I've also had the experience of using telemedicine and, hold that up. They can see my throat, ask me questions, etc. And I know that that's becoming more and more available in the rural communities. So I'm always open to say, make sure people stay within their scope of practice, but let's allow as many people as possible to have access to medical care. One of the testimonies said something about copays as a block to service, but I would expect if pharmacists were going to be expanding their services, there would be some kind of a copay. There would be some kind of a payment for these services. And so my question about all of this, more than just a comment, is most pharmacies now, especially the chain stores, have urgent cares or PAs available that you can just do a walk-in, don't necessarily need an appointment to see a physician's assistant, and they are limited in what they can do. So we're all for offering more services for medical care, but when I see things like pre-exposure and post-exposure prophylaxis and treatment, and flu, my doctor has often said, it's the flu. There's no real treatment for that. So I would go home, drink lots of water, get rest, and, might want to get some Theraflu if you like. Is that going to be the same thing that's said with pharmacists? I don't know. But I feel like that while the bill that we're seeing today, I agree. It should be more collaborative between the doctors and the pharmacists, and I hope that that happens. Thank you.
One last question, Senator Holscher.
Thank you, Mr. Chairman. This might be for Rachelle. You were talking about a more collaborative approach, including the physicians. And, the thing that went through my mind is obviously we're talking about a lack of access. And I experience it in the urban areas with myself, my kids, that type of thing. And then the thing that went through my mind is, okay, now if we're looking at a more collaborative approach, does that slow it down? Because obviously in some of these situations, that's part of the issue, the lack of access, and then you have to wait when, we could potentially more quickly get something to people to help treat them sooner. So can you expound upon that just a little bit, please?
Yes. I want to be clear. I think the collaboration needs to happen in two places. First of all, because you're being asked to make a legislative change, I think the collaboration should happen on the front end. There should have been more discussion before this bill was brought. And because that way we can establish a system that reflects those things and allows it not to slow down at the point of care. So that would be my first answer is there was no meaningful discussion about this. It was presented to us as a courtesy, and we said, hey, we have these problems, and it was introduced a couple days later. So there is, and I want to be honest about this, again, the pharmacists and the physicians, both organizationally and in the real world, have a good relationship. They really do. And we've had good conversation. It didn't happen on this issue. So that would be the first thing. The second thing I would say is in reference to this idea, well, we may have an access problem, or a physician might say, I've taken your strep test, I'm not going to get your results back yet, but it looks like it, and so I'm going ahead and treating. A physician, and I think Dr. Steffen made this point, has the training to also rule out other things with or without that test. Now, they need to do it. It's a part of a differential diagnosis. So it's not quite as simple as just we must do this or we're going to not have access, because that doesn't really take into account the clinical differences in those outcomes. And so I would just say that if we're going to have a bill that represents all of those things, you know, the appropriate amount of access and outcomes, clinicians should have talked this out first and to figure out where that line ought to be. And again, what's the role in those agencies in making sure that there's accountability so that that access isn't resulting in bad outcomes?
Thank you. Committee, we are out of time, but just a couple of little comments that we have. I was hoping to do what work we had today, but we did run out of time. So we'll have a meeting tomorrow at 8:30 to work our final bills, because tomorrow is the deadline before turnaround. Also a note to committee and also conferees, especially on these bills that we took a 30,000-foot look at, trying to get, because we had a lot of new members this year, so I thought it was very important that we had at least a introduction on some of these bills. It's obvious that we didn't have a lot of time to really delve in and get into the deep weeds. So just a note for committee members and conferees, next year, we are going to address some of these battles. As a chairman, I do not want to have a battle every year of the same thing. And sometimes it gets hard because we feel like we are the referee between two really good friends, and we don't want to upset either one of them, but we also don't want to see the fighting continue. So hopefully we will not continue on whose lane are we in and whose lane should we stay out of. So I would really encourage conferees on any of these issues that we took a 30,000 look, or even ones that have been in the past that have been every year, come together, come up with a conclusion, an agreement, bring that to us before next session, because good, bad, or indifferent, we will probably address those so we can get those behind us and we can start moving forward. With that, we are adjourned. Thank you.